Good afternoon, everyone. Thank you for joining me today for our FHO Optimization and Outside Use Management Strategies webinar. We have a great presentation for you today. We will be recording this, so if you do have any questions throughout, just hang on to them. You can review it after or send me an email with your questions or give me a phone call. I do kindly ask that everyone keep themselves muted as well as turn off any webcams. Today, everyone will be viewing what you see on the screen now, so it's a PowerPoint presentation. Again, any questions you have, please write them down, and we'll get to them after the presentation. Thank you, and I hope you enjoy. So we have a lot of new people here today, so I want to go into a little bit about Cirrus Consulting Group. We were founded back in 1994. We have about 50 employees now, headquartered in Toronto. We provide business solutions for both doctors and dentists to make sure that their practices are running smoothly. Two of the main areas of expertise for our company are office lease negotiations and then the Cirrus Healthcare Consulting Division, which we're going to speak about today. So we provide billing support and operational consulting for physicians, both on the group and individual level. So some quick facts about physicians in Ontario today. They're better compensated now than they ever have been in Canada. The FHO model really has introduced a better way of being paid, and the doctors are making a lot more money than they ever have before without working even harder than they need to. More than 75% of all physicians say that they don't get paid according to the care they deliver. A lot of times we find that physicians are providing the care to their patients, but not necessarily seeing fair compensation based on the care they're providing. A lot of people think that their access bonus will never be positive. That is, really not true. We have a ton of physicians that we work with. I would say actually the majority, almost 90%, are positive. The ones that are negative are working in areas where it really is difficult. Very urban areas where there's a ton of walk-in clinics around the corner from, on every corner, and it really does make it difficult, but it definitely isn't impossible. Where there's a will, there's a way, and we definitely strive to work with all of our clients to make sure that their access bonus is positive. And again, people are not necessarily being strategic in how they're paid. The FHO model can be very complicated. There's a lot of moving parts. There's a lot of things that go into it. And a lot of physicians just aren't aware of what it means to be in the FHO model and what it means to be paid through the capitated payment structure. So we're going to get through all of that today, and we really do want to provide a better understanding and ongoing support to help all you physicians out there make better decisions and make sure that your pay does align with the care you're providing. So the purpose of today's program is to guide you through the FHO income streams, give you a little bit of a better understanding about how you're being paid, and to give you a much clearer picture of what the FHO is all about. So how are you paid? So the FHO model is a payment model whereby you're given a monthly payment for every patient that you have on your roster. So whether you see that patient or not, there is a value to having that patient on the roster, and you're going to be paid monthly for having that patient there as opposed to being paid for every time you see that patient in the office. So we're not necessarily looking for the volume anymore. We're not looking to see as many patients as we possibly can in a given hour. Rather, we want to bring in those medically necessary visits for preventive and complex care. Those patients that really do need to come to the office, not the ones that have a little sniffle or a little cut or something like that really don't need to come in. Bottom line, throughput versus access. Again, providing access, making sure that those people that need to come in the office are able to come in rather than bringing everyone in. So the income stream breakdown over here, you can see there's 6 different payment streams within the FHO model, and each one provide a different amount of your fixed income every year. So capitation payments are about 77% of your fixed income. That's what you're going to receive on a monthly basis, guaranteed. Your fee-for-service billings, variable depending on how many patients you're seeing, what type of services you're providing to them. Your access bonus, again, variable depending on the level of access you're providing, how often your patients are going to the walk-in. Shadow billing is based on the number of visits that you're providing for in-basket services, the 15% that you're going to receive. Preventive care bonuses, again, depending on how many services you're providing for each of those patients in each category. And then your special premiums, again, 8 different categories. Again, if you're providing care in each of those categories, you have a bonus potential. If you're only providing in some, then we're going to make sure that you're going to attain that value as well. So capitation payments. Capitation and salary and all these things, they're all synonymous, and you'll hear that a lot going around. Basically, the capitation payments is a fixed salary that you get for having a patient on the roster. On average, $215 per patient per year based on the age and sex of the patient. So an 85-year-old female will earn you more than a 17-year-old male, for example, because that 85-year-old female will demand more care. So purely based on that, that's how they decide who's worth what. So on average, if you have a nice balance across your roster size, you should be earning about $215 per patient. Now, this $215 is essentially a prepayment for the 126 fee codes that are considered in-basket. That's your standard care that you're going to be providing to your patients, such as an A007. Any other service that you provide to your patients that is not part of that 126 fee codes is considered out of basket, and you will get the full fee-for-service value of that code. So here's a breakdown of the payments by age and gender. You can see the orange is the female, so typically about $150, $160 when they're born, and then drops down till about the age of 14 for females, where it starts to go back up again. And for males, it doesn't go back up again until their early 30s. So again, females obviously pay more. In most cases, they do demand a little bit more care, so that's why the ministry has provided a little bit more compensation for having females on the roster. But it really is important to have a nice mix of all your patients across the board. You don't want to have too many old, too many young. You want to have a nice variety. And the natural progression of a roster is to shrink as people age, people pass away, people move away. So it really is good to offset all those patients with some of the younger and newer patients. So roster management. Roster management is essential in the FHO model because so much of your income is directly correlated to your roster. Now, ensuring the proper roster composition, making sure, again, that you have a good balance of all age groups and sex, alignment of your roster between your MOH and EMR. So we find that a lot of times people will believe that they have a certain amount of patients rostered to them because their EMR or their computer system says so, but you also have to double check with the Ministry of Health because a lot of times they never got rostered, they've fallen off the roster, whatever the case may be, your MOH might not have all the patients you believe to be rostered. And then again, building your roster to meet your personal goals. Now, every physician is different. Every physician has different goals and aspirations. Some want a really large roster and want to work a lot more. Some want a little bit of a smaller roster and want to work a little bit less. It really is dependent on each physician, and we're there to help you and build that roster that will suit your needs most appropriately. So having that balance between the roster size and providing the access to the patients is really important as well. You know, yes, you could have 2,500, 3,000 patients on your roster, get paid a lot of money for that, but if you can't provide access to those patients, it really isn't a good fit. Now, how do you roster a patient? There are two codes that you should be submitting when rostering patients, the Q200 and the Q013. The Q200 will actually trigger the rostering of the patient, so that's a mandatory code that you need to submit. And the Q013 is an incentive code, and you'll get paid this incentive for up to the first 60 patients per year, per fiscal year, so April 1 to March 31. You can see at the bottom there, there's different values that are put on the Q013 depending on the age of the patient. So it really is important to keep that in mind as well. We get the question of, from a physician saying, I really want to increase my income by a significant amount. What's the best way to do that? The best way to do that is to increase your roster size, assuming you are able to provide access to those patients. Now, for just 25 additional patients, you're looking at just over $5,000 in additional income per year. Now, if you were to look at 200 patients, you're looking at $43,000 per year. So it really does make a good impact in rostering new patients. The other reason we show you this is because, as I said, it's important to know if the ministry has all your patients rostered that you believe to be rostered. We had a situation not too long ago where a physician was missing over 300 patients that he believed to be on the roster but weren't actually rostered with the Ministry of Health. So he was losing out on $60,000 per year because he didn't want to do a roster reconciliation. Once we did that with him, once we convinced him to do it, he was able to reconcile and get that money moving forward. So fee-for-service. In the fee-for-service payment stream, you have to look at it in two groups, enrolled patients and non-enrolled patients. So I spoke earlier that your enrolled patients are essentially prepaid with that average of $215 per year for that 126 fee codes. Now, what happens when you have all your out-of-basket codes that aren't part of that 126? So anytime you see an enrolled patient for an out-of-basket code, you will get the full fee-for-service value. Now, anytime you see a non-enrolled patient, whether for in-basket or out-of-basket services, you again will get the full fee-for-service value. Now, the ministry does put a limit on the in-basket services provided to non-enrolled patients just because they don't want patients to remain unenrolled. They want the doctor to actually enroll the patient. So there is a hard cap of $60,000 per year. However, in the first year of joining a FHO, there is no hard cap. So they allow you that time to get settled and make sure that everyone is that you want to be on the roster is, so that they give you that 1 year leeway or grace period to make sure that everything is running smoothly. Now, the hard cap is pulled together on the group level. So if you did have 10 physicians in your group, you would have $600,000 approximately across the whole group to spend on your in-basket services to non-enrolled patients. And we don't typically see this to be an issue. We have had an instance where the clinic was running a walk-in clinic as well. So that's where it came into play, where they got close to their hard cap limit, but we've never seen anyone go over. But if you guys are worried about that, or if that's something of concern, please let us know, and that's something that we can look into and have further discussion on. So some of the key areas for out-of-basket codes are diabetes management, smoking cessation, and after hours. Those are the most common. However, on the right here, you'll see our FHO practice billing guide, or we call it our cheat sheet, that you can keep around you when you are doing your billings to see what are the common out-of-basket codes. What should I be billing? Instead of billing an A007, is there something more specific I could bill? Did I provide a different type of service? And am I eligible to bill a K code or something else that is out of basket that I will get paid a little bit more for? We're never looking to incorrectly bill. We don't suggest that. We want to make sure that your pay does align with the care you're providing. So for example, diabetes management, the KO30 billable up to 4 times per year and the QO40 billable once per year will provide you quite a bit of additional income, purely based on the average roster size of about $1,500. You're looking at $26,000 to $30,000 in additional income based on the average roster size of 120 to 140 patients that are diabetic. So it really is important to keep track of your diabetic patients and make sure that you are billing all the appropriate codes. Now, smoking cessation as well. It's a big one, and almost everyone has some, a handful of patients at least that are trying to quit smoking. So as long as you have that conversation with them during an assessment, you're going to bill the E079, and then within the first 365 days of billing the E079, you can bill 2 times the KO39 and the QO42. and that provides you about $100 extra per year per patient. So again, based on the average roster size in Ontario, you're looking at about $15,000 in additional income. So really is important to keep track of that and make sure that you are billing for those smoking codes. So let's talk a little bit about your net access bonus. The access bonus is something that's paid out to an individual physician, but it's based on group performance as well. So every physician will start the year, so it's broken up into two periods, April to September and October to March. Everyone will start with approximately $62,000 per year, so $31,000 per half. And every time one of your patients goes to a walk-in clinic, it will get reduced dollar for dollar. So it really is important to keep track of your patients and make sure that you're providing that access. As I said, it's based on group performance, so negative members do impact those that are positive. So if the group is split and half the group is positive $10,000 and half the group is negative $10,000, unfortunately it does equal out to zero and nobody will receive anything. So it really is important not only for your own access bonus, but for your group members' access bonus as well, to keep track and make sure that everyone is doing their part to provide access both during the day and after hours, and really letting the patients know that it's a full service office, that you want them to come to see you rather than to go somewhere else. So a little bit about patient management for outside use. So outside use is a daytime issue. Allowing same-day urgent appointments is critical. We find that Mondays in particular are considerably bad for most groups as people get sick over the weekend and they call in Monday morning, they need to get an appointment for them or their children or whoever, and they just can't because it's a Monday and everyone's calling in. But leaving those appointments open during the day is really important, and making sure that those patients do have the ability to call in or come in and see you guys is important. So assessing the needs of the patients, trying to figure out which days of the week are busier. Like I said, Monday is typically a busy day for most offices. If your office happens to be busier on a Wednesday, then so be it, and you'll adjust your schedule on a Wednesday, for example. All those things are really important and definitely something that we help with on a regular basis. Patient information, like collecting information from the patient, so collecting their emails, office phone numbers, things like that, to make sure that you're able to get in contact with them when needed. With technology being so advanced now, and everyone having a phone with them that has connected to email or things like that, it really is important. Collect that email address, send out blasts to all your patients, letting them know about clinic changes, time changes, things like that, important notices, if doctors are going to be away, who's covering, things like that. It really is a good way to connect with people, being in 2014 as we are. And provide extra hours or more open spots on busier days and less on quieter days. So again, it all comes back to assessing the needs of your patients and really paying attention to your office and what's going on. Not scheduling longer appointments, such as physicals, on busier days is really important. Pick a quieter day, Tuesday or Thursday, for example. Most offices are quieter, so have all your physicals done on that day, or your longer tests or appointments that can be done on those quieter days. Bottom line, the patients need access. So making sure that they can call in, they can walk in at any given time and get us an appointment the same day, or at the very latest the next morning, is extremely important to providing patient access. So how do we manage outside use? So of course it is hard to control patient behavior. I mean, at the end of the day, the patients are going to do what's more convenient for them. If there's a walk-in clinic next to their office and their doctor's office is 45 minutes away, chances are they're going to go to the walk-in, which is somewhat understandable in an emergency situation. You have to let them know. Patients are often unaware of the impact. So do we want to say that the doctor's losing money when the patients go to the walk-in? Not necessarily. Some patients might not take that the right way. But you can put it along the lines of, the continuity of care. When they go to the walk-in, you have no idea what's going on. You don't get a report to say that, Mrs. Smith came in to see me for X, Y, and Z. You just don't get that. Or even letting them know that the ministry is essentially double paying, and the taxpayers are double paying. So, every time you go to the walk-in, that doctor is being paid, but you're also being paid to provide care for that patient. So essentially, it is double payment by the ministry. Not having any appointments open during the day, again, you need to have appointments that people can walk in or call in on the same day. Patients not being aware of the after hours. It's really important, being in the FHO, you are required to provide a certain amount of after hours slots depending on the group size. So letting them know that, whatever nights of the week you do provide or on the weekend, that it is available to them is also very important. And your referral patterns, making sure you're aware of who you're referring to. If it's a sports medicine doctor that you're referring to, make sure that they have that focused practice designation, or a GP that provides psychotherapy, make sure that they have the focused practice designation. Otherwise, it will impact you and your access bonus. So some of the best practices, as we've been speaking about, is to analyze and determine which patients to move from the fee-for-service, from the roster to the fee-for-service bucket. So which patients are going on a regular basis, which patients are, seeking counseling or, addiction or pain management or whatever the case may be. And let's move them from the roster and get paid for fee-for-service every time we see them instead. You can de-roster back to the earliest date of outside use or 6 months. We do find that in some cases the ministry will go back a little bit longer, but it really is a hit and miss situation with the ministry. We really never know what they're going to do or what they're not going to do. So, go back at least 6 months to, if need be, and in some cases you can go back to the earliest date of outside use if it is longer. So whichever is most appropriate, that's what you should be using. It is a daytime access issue, so again, ensuring those same-day spots are open. Ensuring that the office staff understand what it means to be in the FHO as well. So making sure that they're not sending patients to the walk-in, making sure that they're doing whatever they can to make sure that those patients are able to come into the office as soon as possible is really important. So staff education really is a great way of trying to mitigate the outside use and get people into the office more often that really need to be in the office. Educating the patients, again, letting them know what it means to be part of the FHO, what it means when they go to the walk-in clinic, that you guys don't get the report from them, the continuity of care is lost, the ministry is double paying, the taxpayers are double paying, things like that are, might help to get through the patients. It's not going to happen the first time for sure, so you will have to tell them over and over again until they really do get it. And again, be aware of the red flag codes. So again, like I said, sports management, pain management, addiction, things like that. Home visits in particular as well. A lot of physicians don't provide home visits, but there's services that do. Med visit, for example, in most cases does affect your outside use. And unfortunately, if you don't provide that care to those patients, there's only so much you can do. So you have to decide at what point it makes financial sense to de-roster. How much of a hit are you willing to take, knowing that you do get paid quite a bit for that patient, but you're going to lose out on your access bonus. So again, all things that we can help you determine and show you the numbers and help you make a decision as to when you should de-roster those patients. So what happens when you de-roster the patient? Essentially, it's just an administrative relationship change, unless you do want to get rid of that patient altogether and let them know that you don't want to provide care to them any longer. You're going to move them from the capitation stream to the fee-for-service stream. So instead of getting a yearly fee for them and paid monthly, you're just going to get paid every time they come to the office. So when de-rostering a patient, for example, if you go back 6 months, you're going to get deducted the capitation over that period. Any shadow billing, so the 15% that you receive for an in-basket service, will get topped up to the full fee-for-service value. All outside use that was incurred will be removed, so you'll get all that money back. And moving forward, like I said, you're just going to see them, you're still going to see them, you're just going to get paid differently. You're going to get paid fee-for-service rather than through the capitation model. So some outside use reporting. So here at Cirrus, we do have a proprietary software that we use in order to produce a report for you. We call it our outside use management report. And it really is important to get that information from you so we can help you to determine which patients to move from the roster to the fee-for-service bucket, helping you to educate the patients. Once you know what the patients are doing, so if you know that they've been going for addiction services for the last 6 or 8 months or 12 months, you can have that conversation with them if you weren't aware of it, or if they're going to a diet clinic, or if they're going to see psychotherapy, whatever the case may be, you'll be able to have that educated conversation with the patient to say, we've noticed that you've been going to, Dr. So-and-so, or you've been having this type of service. Who are you going to? And why are you going? Why aren't you coming to see me? Is there any issues? Things like that, having that key messaging and letting them know that you are aware and you are here to help really is important. And again, ensuring that the office staff know what to say to those patients as well. Again, you can determine which patients you want to bring in and which patients you don't. So at a high level, here are 2 snippets from our outside use management analysis report. On the left, you'll see what codes are being utilized outside the office. We'll always provide you with the top codes that are being utilized and what percentage they are being utilized. And on the right, you can see what days of the week are the highest for outside use. So like I said earlier, if Mondays happen to be the highest, you can know that and you can adjust your schedules as necessary. Or if Fridays happen to be the highest, again, you can adjust as necessary. So here you can see a list of 20 patients. We'll always provide this for you. It's always going to be a list of 20. Whether or not there's a full 20 that should be considered for derostering is not always the case, but we will always provide a list of 20 so you see who's going where. And we'll show you the income versus cost breakdown. So in the green column, you'll see the prorated capitation over the 6-month period. And in the orange column, you'll see what the impact was of outside use over that 6 months. So for the first patient there, you'll see $85 in capitation for 6 months, but $582 in outside use. So obviously, they've been eating away at your capitation, so you're really not earning anything by having them on the roster, and you're losing out quite a bit by having them because you're not getting that from your access bonus. That $582 is being removed from your potential payment from your access bonus. So we will always show you that breakdown. And on the far right, you can see the return column. Anyone greater than 100% means you're earning less, you're not earning anything by having them on the roster. So it really is a good idea to deroster, unless it's something that, is very short term, it's going to stop and it'll balance out as the year progresses. So again, really good opportunity to sit with us and look at these reports and really have an educated conversation to try and figure out who you want to deroster and who you don't. On the next page of the report, you'll find the number of services over the number of months that has been incurring, as well as what services have been utilized. Again, keep your eye out for those red flag codes, the psychotherapy, the sports medicine, the general assessments, the periodic health visits, things like that to show that maybe you're not the primary care provider anymore, or they've been going for addiction services or psychotherapy counseling, and maybe it's something that's going to continue for a long time, so you do want to get rid of them from the roster so they don't impact your outside use any longer. So preventive care. There's 12,800 available for you throughout the 5 categories. Now, everyone is going to be different, obviously. Everyone has a different roster size. Everyone has a different practice style. Some people don't have any females. Some people don't have any children. Whatever the case may be, we want to make sure that you are earning your top percentage in each of these categories. That's the best of your ability. So making sure that you're looking at your target reports that come out in October. So it should be coming out. It should have come out already to show you how many patients you have in each of those categories and who's going to need the service over the coming months. Be sure to build tracking codes, exclusion codes, to make it easier for you when your end of year report comes out in April to show what's happened over the past 12 months and what your patients have achieved or haven't. So like I said, twice a year it comes out, April and October. The April report will show you your total calculation for the previous year. So it'll show you in each category your patients that were eligible for the service. It is a good idea to go through and double check and make sure that all those patients that the ministry has claimed haven't received the service did in fact not receive it, or if they did, then you need to include them in your calculation to get a higher percentage. Sometimes even one patient can make the difference between moving from one percentage level to the next. So it really is important to go through and double check and make sure that the ministry did in fact calculate all of them, and if they haven't, then that you add it in manually. Special premiums. So special premiums, there's 8 categories for a total of potential of $37,000. And for your CMEs, there's a total potential of $2,400. So the 8 categories that are available are here. Again, not everyone is going to provide service in all of these categories. In fact, I don't think I've ever seen anyone hit all categories. But we do want to ensure that if you are providing service in any of these categories, that you do reach the bonus thresholds that are available to you and to the best of your ability. Serious mental illness is probably one of the easiest ones to get for the most part, as well as office procedures. Some of the other categories, it really depends on your practice style. Again, not everyone is going to provide home visits. Not everyone is going to have palliative patients. Not everyone is going to provide long-term care. So, again, it really is a personalized bonus levels, and we want to make sure that each one of you are maximizing to your potential. For CME credits, you have, like I said, $2,400 available to you. If you don't max out in any given year, it will carry over for 1 year. So if you only get 2,000 out of the 2,400, the next year you'll have a potential of 2,800. There is a limit on the Q556 credit, which is your main Pro M1, to 80 out of the 96 credits. The remainder can be a combination of your main Pro Cs, your conferences, the Q555, or your other, so your journal readings or discussion with colleagues, research, teachings, things like that, which is the Q557. So it really is important to bill for these as you complete them. We want to make sure that you don't lose out on anything that you have completed. They do expire after 6 months of completion. So, if you've done something today, make sure you bill for it. Don't wait for 6 months, or don't wait till the end of the year and submit everything for the whole year past, because you won't get everything. You won't lose the money because it will carry over for 1 year, but essentially you're not getting credit for what you've already done. So some of the key takeaways for today. Again, ensuring that the patients you're seeing are actually on the roster. The capitation payments make up the largest amount of revenue in the FHO, so it really is important to make sure that your EMR roster, or your computer roster, or paper roster matches up to your Ministry of Health roster. So it really is important to take advantage of doing a roster reconciliation and making sure that everyone you believe to be on the roster is in fact on the roster. Remember to submit the corresponding Q codes when rostering patients. So the Q200, the Q013, you will get paid for up to the first 60 patients for the Q013, so it's important to know that. There obviously is a value to rostering some of the older patients, so if you wanted to keep it for that, by all means, just be aware of that. Preventive care, again, making sure that you're submitting the tracking and exclusion codes. It makes your life that much easier when the report comes out in April to see who has had the service, who hasn't, who's eligible, and who's not. Outside use is a daytime access issue, so making sure that you have those open spots during the day is extremely important. Making sure that you're providing the access to those that are medically necessary, not bringing in those that don't have to come into the office, but rather those that are medically necessary. You have the ability to de-roster retroactively, so use our management analysis, our outside use management analysis to have that educated conversation with the patients and determine whether or not you want to de-roster, and of course, de-roster retroactively. Most importantly, we are here to help. Any questions or concerns you have, any of the reports, anything at all, We love to hear from you, email, phone call. We'll set up a meeting. We can have a phone conversation, whatever is easiest for you. We're here to help, and we want to make sure that you guys are working to the best of your ability. We want to make sure that you're working smarter, not harder, and making sure that you're being paid for the care that you're providing. You know, everyone is different, so we do suit our services to every individual practice or to the entire FHO. And like I said, everyone works differently. Everyone has different goals or, you know, aspirations. So we want to make sure that everyone is running to the best of their ability. So how does Cirrus help my practice or FHO? So income flexibility, work-life balance. Those are some of the key terms that really come up a lot, and people don't want to work as hard anymore. People want to work smarter. They want to work more efficiently, more effectively. So having that balance between all these aspects is really important, and it all starts by taking a proactive role of your practice. Not necessarily the clinical side always, but it really is important to know everything that's going on in your practice and making sure that you are running efficiently. So FHO education for physicians and staff. We provide education sessions all the time for both staff and physicians. We can come out there, do a presentation for all your staff, make sure that they understand what it means to be in the FHO model, what their messaging to the patients should be, and what your messaging to the patients and staff should be. So it really is important to have your staff educated. Governance agreements, making sure that your group has a governance agreement is extremely important to make sure that everyone is working fairly, nobody's taking too much time off and not getting a locum to cover. So a governance agreement really is important to have in place. Group banking, so you know, if that's something that's a little troublesome for you guys, by all means, let us know. It's something that we can help you with. Income optimization, again, making sure that your pay is aligning with the care you're providing, bottom line. And our Cirrus Helps hotline. We're here to help. As I said earlier, no question is too big or too small. Please let us know if you have any questions. There's a team here that will be able to get you the answer as quickly as possible. So please do reach out by phone or email, and we'll be happy to help you. So we do provide a number of services, or a number of reports, I should say, the Cirrus Performance Index to show you how your practice is performing, our outside use reports, usually on a quarterly basis, but can be done more often, RA summaries, again, making sure that you understand how you're being paid. The RA is extremely complicated to look at for some people, so we're happy to do that for you. We can meet with you monthly, semi-monthly, you know, every 2, 3 months, 4 months, whatever you guys decide, to go over that and show you how you're being paid. A roster reconciliation, we think you should do it at least twice a year, but you know, for sure once a year. And our special premiums update as well. We give that out twice a year. And then, of course, our Cirrus Physician Portal. We provide lots of resources, lots of reports up there. Everything that you guys send us and everything we provide to you is there. Each of our clients has their own folder, and you'll be able to log in, see everything that has been done from the previous couple months or year, and again, all the resources up there for if you have any questions. So we work section by section, you know, income stream by income stream to make sure that everyone is working effectively. So capitation payments, so you have to do a roster reconciliation. Fee-for-service billings, making sure that you can increase your revenue by billing out-of-basket codes. Net access bonus, managing your outside use, knowing who to deroster and who not to deroster. Shadow billing, optimize your practice style. So billing having enough patients come through the door to get that extra 15%. Your preventive care bonus, making sure that you're billing your tracking codes, exclusion codes, and making sure that you're submitting it before the end of September. You do have that 6-month period from April to September to submit it, but obviously the sooner you do it, the better off you are. And of course, your special premiums. If you're providing the care, then you should be paid for it. So making sure that you're billing the right codes in order to get your bipolars and schizophrenics, or your home visits, or your prenatals, or whatever the case may be. So here's a sample of how we support you over time. You know, we'll provide everyone with a month-over-month overview to show what we're going to do, so you have an idea. Again, this can be tailored to each individual physician in the group or to a group as a whole, whatever is most appropriate for you guys. We want to make sure that everyone is working to the best of their ability, and again, everyone works differently, so we tailor it to each individual physician. So a little bit about our professional fees. We charge $425 per month per physician, and we have a team approach, full team support, analytical expertise. We're the leaders in practice optimization and revenue generation, and we have customizable programs. We're going to make sure that the program is right for you. You're buying an average increase of about 18%, greater flexibility in work-life balance, increased control over roster and practice, and reduced overhead in some cases, and a higher performing FHO. At the end of the day, we want to make sure that you guys are running smoothly and making sure that all your questions are answered and that everyone is working better. So that brings us to the end of our presentation for today. You have my contact information, both email and telephone number. We have our toll-free number as well, so please don't hesitate to reach out and let us know if you have any questions or concerns. If you'd like more information, I'd be happy to speak with any of you, and I do appreciate you taking the time today to join us. And again, it was being recorded, so if you have any questions or you wanted to go over it again, or if one of your colleagues wasn't able to join us and would like it, please let us know, and we'd be happy to send it off to you. Thank you again, and I hope to speak to you soon.